Welcome, everyone. It is lovely to have you here at this NHS England Lunch and Learn webinar on type 1 diabetes in children and young adults age 0 to 25. We have a very packed agenda for you, so I'm just going to quickly welcome you. My name is Candice Ward. I am the CDEP lead, and I am going to be your chair today. We just want to take this opportunity for you to say hi to each other in the chat. So you have the chat function that is used just to talk to each other in the webinar. But if you want to ask any questions to the panelists, can you use the Q&A function, please? So the Q&A function is for the questions. We will take the questions at the end. If there are a lot of questions, we will answer them as we go along as well. But the chat is to say hello, who you are, where you're coming from, and to have a conversation. You will also see that there are reactions. Please feel free to use them. The emojis are there for you to interact as well. If you do have any technical issues, it might be worth just leaving and coming back if your sound isn't as good as you should or something's happening. Sue is around in the chat also to help you if you've got any questions. So please do reach out to Sue at CDEP admin via the chat. Just another warning that this webinar is recorded, but any attendees will not be seen. Only the panelist videos will be on, so your privacy will still be protected. Right, we have three wonderful speakers for you today. They will do a little bit of an introduction when they start their section, but I just wanted to introduce you to Fulya, Verity, and Reza, and they are the experts around type 1 diabetes in children and young adults, and will take you through the agenda. I'm first going to hand over to Verity so she can take us through her section. Thank you, Verity.
Thanks, Candice. Yes, I'm Verity Hawks. I work in the NHS England diabetes programme. So in this first section, we're just going to cover some key headline data on children and young adults with type 1 diabetes, and we'll show you where you can find local data on your populations. So see if I can move the slide. Yeah, there we go. So in 2021-22, there were just under 60,000 people aged 0 to 25 with type 1 diabetes, and about 30,000 were cared for in paediatric diabetes units. There's been an increase in the number of children with type 1 diabetes since the pandemic, but we're not entirely sure of this. But in 2021-22, there were 884 more children newly diagnosed with type 1 across the country compared to the usual number diagnosed per year between the previous sort of 7 years or so. So I just wanted to note that for commissioners to be aware if there's any impact on their local caseloads. Moving on to average HbA1c levels, key marker of blood sugar management in paediatrics, have improved over the last decade, and they've reduced by 10 millimoles, down from 71 in 2010-11 and to 61 last year. However, these levels are still higher than the NICE treatment targets of sort of 58-48. But some of the drivers behind these improvements is the fact that we've had an excellent national paediatric audit. There's been a paediatric best practice incentive tariff. There's been some great clinical networks operating in this space, a quality programme run by the Royal College, and advances in diabetes treatment technology. But I think it's important to say that underneath this overall increase, inequalities in outcomes exist between groups of people with type 1 diabetes. For example, HbA1c is 7.5 millimoles higher in those living in the most socioeconomically deprived areas compared to those in the least deprived areas. And there's also variation in care and outcomes across the country, some of which is unwarranted. And moving to the next slide. One important example of unwarranted variation that I wanted to highlight is the completion of key annual health checks. So this chart shows that completion rates range from 22.1% to 93.5% across integrated care systems in England, and that's quite a wide range between systems. And this is just a really important metric as well, because the completion of annual diabetes health checks are associated with improved outcomes, including earlier identification of complications, reductions in premature mortality, fewer emergency hospital admissions, and as well as subsequent reduced healthcare costs. Some key things to highlight here. Next slide. So yeah, also as attendees on the webinar to be aware of some of the national support for improvement that's forthcoming. So the first one is the Getting It Right First Time programme. So GIRFT is a clinically led programme designed to improve the quality of care within the NHS. And NHS England's Children and Young Adults Diabetes programme has partnered with GIRFT to establish an approach to improve care for children and adults with diabetes. Over the next 18 months, the programme will facilitate visits to every system. These will be led by a assistant team of diabetes experts, and will jointly look at data, discuss the challenges faced locally, and share best practice across providers and systems. The approach is going to cover care up to 25, so that will include both paediatric and young adult services. And doing this programme at an ICB level gives us that opportunity to include commissioners of care, decision makers, and take that wider view. So look forward to that programme starting soon. Also wanted to highlight that we'll soon be publishing a Right Care Toolkit on children and young adults diabetes. This is being co-produced with an expert group, including representatives from Diabetes UK, commissioning leads, clinical leads, and NICE, and it will bring together guidance, standards, and good practice and data all in one place to support commissioners to improve the care pathway. And this will be a complementary sort of supportive toolkit that will help in the GIRFT discussions as well. But one of the most important things to support improvement, we'll go back, is data. It's just going to go forward. Candice, I don't know if you can go back, but otherwise I'll just go from here. So yeah, in addition to some of those, thank you, in addition to those national headlines presented at the start, we're interested in how these manifest at a local level. And we've been working with the national audits to make the data more accessible. So we've got the relevant dashboards listed on this slide, and then I'll go through a couple of them now. So let's go forward. Yeah, so this is the landing page for the National Diabetes Audit dashboards. So there's core annual, core quarterly, and what I've highlighted there is the adolescent and young adults dashboard. And then the next slide goes into that and shows you what it looks like. So it contains data on people with type 1 diabetes aged 15 to 25 years, and it includes data cut by sex, ethnicity, deprivation quintile, includes body mass index, so obesity, overweight, HbA1c, health check completion, insulin pump usage, and admissions data. And the data is available cut at region and ICB level. And what I've got presented here is an example of the percentage of people with a high blood sugar level, so over 86 millimoles, at various ages across the three systems in the Northwest region. So that's a really useful dashboard and resource, and going forward it will be updated annually. The next one to highlight is the National Paediatric Diabetes Audit Results Online tool. So this has the data for those cared for in paediatric diabetes services. It's open access, doesn't have any login or password restrictions, and includes data at sort of unit service level, system level, network and regional level. And here we've got the health check completion data by various units in the Southwest region. So yeah, definitely recommend going into that and having a look at your local data if you've not already. And the third and final one to highlight is a DKA dashboard that's hosted within the NHS England Transformation Programme dashboard. And this includes data on DKA admissions, those 0 to 25, including DKA admissions with a pre-existing diagnosis of diabetes and those where diabetes has subsequently been diagnosed following the admission. So that was the data section. Thank you very much. I'll pass on to you, please.
Thanks, Verity. So hi everyone, my name's Fulya. I'm the clinical lead for the Children and Young Adults Diabetes Programme at NHS England. Thank you very much for the opportunity to talk to you about children and young adults diabetes. We know we've got a really varied audience, so hopefully we've picked out topics that will be of interest to everybody. And one of the key things that we wanted to talk about was diabetic ketoacidosis. So DKA is a life-threatening condition that can happen at first diagnosis of diabetes, but can also happen in children and young people with an established diagnosis of diabetes. And it's a largely preventable condition. So it's important that we do everything we can to try and ensure that young people don't develop this. So in terms of the data, Verity's already mentioned about the DKA dashboard, so that's really helpful to look at what your local data looks like. But when we look at young people with an existing diagnosis of diabetes, we can see that rates of DKA steadily increase with age, and we often find that this is a particular issue in during adolescence as young people become more independent with their diabetes management. We also see a strong relationship with socioeconomic deprivation, and those children and young people living in more socioeconomically deprived circumstances being at higher risk of developing DKA. I think the key things that we can do as healthcare professionals in this area are to ensure that young people and families have the education in terms of preventing DKA, so managing high glucose levels and high ketones. From a primary care point of view, ensuring that they always have adequate ketone test strips so that they can test if there are any issues, and ensuring that we've got really clear pathways of care for how families can access advice and support. And also sensor technology is becoming increasingly important in this area as well, in terms of reducing acute admissions. When we look at diabetic ketoacidosis in new diagnosis of diabetes, again, this is a really concerning area because the latest National Paediatric Diabetes Audit demonstrates that we've steadily had increasing rates of DKA at diagnosis over recent years. And it's important that we think about what we can do as systems to try and reduce this. We again see the socioeconomic impact with those children and young people living in more economically deprived areas being more at risk in terms of presenting with DKA at diagnosis. So there are two strands really to try and have an impact on this. Firstly, it's around raising public awareness, and secondly, it's healthcare professionals being more aware of how children and young people can present with diabetes. So Diabetes UK have done quite a lot of work in raising public awareness with the 4Ts campaign. So the signs of diabetes to look out for are obviously needing the toilet more often, so passing more urine, being excessively thirsty, increased tiredness, and thinner, so weight loss. And I think there's a real opportunity here. I know we've got a mix of people on the webinar, so for example, school nurses or people working in urgent care, primary care. There's an opportunity to raise awareness of the signs of diabetes, and there's lots of resources available on the Diabetes UK website that you may find helpful. The second strand that's really important is for healthcare professionals to be aware of what these signs may be. So in addition to the 4Ts, some of the differences in children and young people might be recurrent oral thrush or persistent nappy rash. Even the excessive urination might appear different in children and young people. It might be bedwetting, for example, which is a difference compared to adults. So we really do have to be mindful of some of those differences that we see in the younger age group presenting with diabetes. And what we would always recommend is that if you suspect diabetes in a child or young person, that they should, on the day that you see them, ensure that you undertake a finger stick blood glucose check. And if the glucose level is 11 millimoles or more, then this indicates likely diabetes, and then it should be a same-day referral, so immediately transferred to hospital for further assessment. Unfortunately, we come across many cases in clinical practice where the healthcare professional has thought of diabetes, but then recommended blood tests are undertaken within the next week or two. But often then these children or young people end up presenting in diabetic ketoacidosis in the meantime before those blood tests have been undertaken. The other story we sometimes hear is that it's sort of been suggested that perhaps the child is too young to develop diabetes, and so it's been dismissed as a potential differential. But of course, you know, we see type 1 diabetes presenting in any age. So again, it's just important to be mindful of that as well. Should the child be more unwell and progress into DKA, then it's very important to be aware of the symptoms of DKA, and they're listed there, and I won't go into them in detail, but I think the two areas that tend to catch people out are respiratory symptoms. So you know, for a child who is tachypneic, so breathing quickly, but there's no chest symptoms, always think, could this be DKA? And abdominal pain, sometimes, you know, presenting as possible appendicitis or other abdominal pathology, but this can actually be DKA as well. So important to think about it when assessing these children and young people. So in terms of preventing DKA at diagnosis, so we currently see rates of around sort of 30 to 40% of children and young people presenting in DKA. There's been a really good piece of work that's been developed by the National Children and Young People's Diabetes Network, led by Michael McGuigan, a consultant colleague at Chester Hospital. And it's a 5-minute presentation, so really quick to go through, and it basically describes the signs and symptoms of type 1 diabetes in children, when to suspect type 1 diabetes, and there's a series of cases to go through as well, which I think would be really helpful, and we've got the link on the slides for people to follow if they're interested. And I've just included the summary slide because I think the take-home messages are really nicely presented in the summary slide, which is, if you see a child with any or of the 4 Ts, just don't ever forget to check a glucose level. It's a same-day test for diabetes with a finger prick blood glucose check, and if you've got a glucose of 11 or more, then it's an immediate referral to hospital for further assessment. And if you've got a blood glucose level of between 7 to 11 or glycosuria with diabetes symptoms, then it must be discussed the same day with a paediatric team. Okay, and I'll now hand over to Reza.
Thanks, Fulya. Morning, everyone, or afternoon. My name is Reza Zaidi, diabetes consultant in Liverpool, and I'm also the young adult advisor at NHS England. So whoever's involved in young adult diabetes care will understand that this is probably one of the most challenging areas in the entire age spectrum in the diabetes world. Also, if you're involved in transition, you face similar difficulties. Now, I'm not going to go through a lot of the data because everyone's seen the impact what this age can have on their diabetes control. But there are a couple of pieces of data that are generated from the adolescent and young adult audit, which Verity highlighted. And that, if I can move my slide. There you go. The first piece of data is the target HbA1c achievement of 58, and you can see that there's a steady deterioration from the age of 15, with the lowest levels seen at the age of 20. So we're talking about the years of transition, as well as probably the year after transfer of care. And then there is a steady increase in young adulthood. But just as from an age perspective, you can see that there is a deterioration. And there is further data also around this deterioration. And that also is seen where young people are, whether they're known to pediatric diabetes services or not, that deterioration is seen in this age group. The other piece of evidence is around the care process completion rates. Again, we see a steady decline in most of the care processes being completed, and then it sort of plateaus across the young adult age groups. Now, everyone knows that there are challenges. We don't know what the perfect model of transition care is. And that's what we're going to be testing out in the Transition Young Adult Pilot Program, which is a 3-year pilot program run by NHS England, where 15 sites across the country have been given bespoke funding to improve their transition and young adult services, as well as sort of inform commissioners, as well as come up with models of care which can impact future commissioning around this area. So in a nutshell, the pilot program is testing a service specification, and the service specification is designed in a way where we look at 4 key areas, and that is pediatric preparation, planned transfer of care. The bulk of the service specification is around young adult specialist services. And then the last and crucial bit of that service specification is around integration with the primary care. The funding goes through till 2025 with the evaluation going to be done towards the end of 2025, so that we can then come up with some sort of model of care, which may be, which may feed into some sort of commissioning in the future. The evaluation is going to be done with one of our independent evaluation partners called Ipsos. Now, the thing that they're looking at the evaluation in 2 areas. They're looking at whether this whole pilot program has an impact, and the impact being defined as engagement, looking at clinical outcomes, well-being experience of young people, as well as looking at whether this whole process is sustainable, whether it's scalable as well, because that's quite important if we're going to decide things around future commissioning. The tools that are going to be used currently is quite an elaborate minimum data set. And along with a patient survey, there's some field work being done from a staffing level as well as young people level to impact on that. And then, through sort of regular peer support meetings amongst healthcare services, a lot of data is being shared, a lot of good practice is being shared. Now, there are 2 areas which I just want to highlight, 2 key messages which have come out from the evaluation so far. One is around approaches to improving service engagement. Now, whoever's involved in transition and young adult care, you will realize that this is an area where retaining young people in the service and improving their engagement is fundamental. So the examples so far that we've come across have been models which have been designed and tested around improving community integration and liaising with primary care. Then liaising with universities, coming up with clinics with flexible timing. There have been examples of peer support groups, use of social media, embedding youth workers into pediatric, transition, and young adult care. And lastly, there are also some good models where teams have been refining their databases with primary care to dig out those young people who have been disengaged, who have been lost to follow up. Some services have started using preclinic questionnaires quite rapidly as well, and they've embedded that in their practice to improve the communication with young people. The other key area is around mental health. Now, we know that 1/3 of young people live with some level of diabetes-related distress or mental health problem, and eating disorders as well. Now, in my opinion, I think 1/3 is as a gross underestimate, because the data and the research that is there, which has been published, and all the data which is there in literature, probably highlights those people who've been screened, and there's a whole world of young people who haven't been screened as well because of the lack of psychology services. But this is a huge problem, and everyone, again, working in this area will understand the burden of that. Now, as a part of this evaluation process, a sample population of young people were sent surveys, were asked questions, and I think that's about 300 odd young people across the country were asked what diabetes-related issues were the biggest problem. And I think the overwhelming majority highlighted that diabetes was taking too much of their mental and physical energy every day. And also, there were significant worries about the complications in the future. So again, this is again a sample population. The incidence or prevalence of mental health issues in this population was more than 33%, or more than a third of the population. So I'm just giving you a snapshot of the importance of embedding psychology support in this area. So I'm just going to hand over to Verity to talk about another important aspect, which is the self-management tools.
Thank you, Reza. We wanted to provide some information about the digital self-management services commissioned by the national programme. So firstly, there's DigiBeat, a platform app and portal for children and young families living with type 1, which includes age-appropriate structured education, multilingual films and resources. And the app also supports clinic-to-patient communications. And within this, today we really wanted to highlight the young adult offer. So here's an example of some of the young adult resources, including topics such as university, pregnancy, etc. I just think there's some really great resources there to check out. So yeah, the app needs to access is through referral from a clinic, and once clinics are signed up to use DigiBeat, they can provide access codes to their patients. And the other self-management resource I wanted to highlight was My Type 1 Diabetes. So this aims to support adult users gain more understanding of type 1 diabetes, how to manage it. People can self-refer onto this tool. It can be useful for ongoing support across the life course. And one thing I wanted to highlight today is that they're running a massive online open course, a MOOC, that will start tomorrow. It runs for a week to help support all people to better understand type 1 diabetes. So yeah, please register that if you're interested, or signpost that to your patients. Thank you very much. And now I'll pass on to Fulya.
Thanks, Verity. So the final area that we're going to cover is the latest developments in technology. So let me get on to the next slide. So I think the first thing to highlight is the update in NICE recommendations. So NG18 and NG17, so that's the guidance on managing type 1 diabetes in children, young people and in adults, has recently been updated to say that real-time continuous glucose monitoring should be offered to all people living with type 1 diabetes, along with education, self-management education as to how to best make use of the technology. And then the second really important development in terms of diabetes technology, which really is a game changer for type 1 diabetes, is hybrid closed loop systems. So just to give you a bit of an overview of what this means, a hybrid closed loop system is where you have a real-time continuous glucose monitor that the person wears and an insulin pump that's also worn, and the pump and the sensor talk to each other through a computer program. And that that computer program might be part of the actual insulin pump itself, or it may be through an app that's on a handset or a phone, for example. And what the pump will do is, in response to the readings from the sensor, it will adjust the amount of insulin that's being given in the background. So whilst patients still need to, carbohydrate count and tell the system when they're eating carbohydrates and input that data, the HCL system will do quite a lot in the background to either give additional insulin as needed, but also reduce the amount of insulin or stop the insulin from being given if it predicts that there might be hypoglycemia developing. So systems they really do a lot to help prevent or minimize high blood glucose levels, and also prevent or minimize hypos as well. And I think one of the really key things, particularly in the world of pediatrics, is what happens overnight. So we tend to find that children, young people and families finally manage to get some sleep overnight once they're able to use these systems, because it does a very good job of keeping them in target when they're asleep, and that can be really life-changing, both for the person living with diabetes, but also for their families as well. And I'm delighted to say, and I'm sure most of you will know this already, but the latest TA from NICE recommends that hybrid closed loop systems are an option for managing diabetes, type 1 diabetes in all children and young people 0 to 18 years, and that hybrid closed loop systems are recommended as an option for adults over 18 years who have a HbA1c of 58 millimoles per mole or more, or have disabling hypoglycemia despite best possible management with at least one of the following technologies, so an insulin pump or continuous glucose monitoring. HCL is also recommended as an option for people who are pregnant or planning to become pregnant. But an important caveat is that the systems are only recommended if they're procured at a cost-effective price agreed by the companies in NHS England, and there's lots of hard work ongoing to secure that for us going forwards. Just wanted to highlight this decision aid that's been developed by NHS England, and it's a decision support tool for people living with diabetes to help them. They can work through the decision support tool and work out what might be the best system for them. And I'd also recommend it if you're a healthcare professional who doesn't know, doesn't have a huge amount to do with diabetes technologies. It's presented in a really nice way and gives you a really good sort of first line information about the different systems and how they work. And this is just a really nice bit of feedback from the latest National Paediatric Diabetes Audit from a young person living with diabetes, where, Katie, she said that it gives her the confidence to remain active during the day and rarely worries about her blood sugar overnight. And I think this is the sort of feedback that we see in clinic all the time when we're looking after young people who have moved on to these systems. So what do HCL systems mean in terms of outcomes? So when we look at HbA1c, this is data from the National Paediatric Diabetes Audit, and you can see different types of diabetes technology and different ways of managing diabetes. And the thing to highlight there is that the hybrid closed loop systems, we see the lowest HbA1c for those young people who are on these systems, with the highest HbA1cs for young people who are on injections and finger prick blood glucose monitoring. So it really does have a very meaningful impact on outcomes and in terms of keeping these young people healthy and safe, and giving them the best possible opportunity of staying well and free of diabetes related complications as they get older. So despite the huge amount of progress that's being made in terms of improving access for diabetes treatment technology, we do continue to see persistent inequalities, unfortunately. And we see this across the board in all types of diabetes technology. It's improving in some areas, but unfortunately, it's not improving in other areas. So again, this is data from the National Paediatric Diabetes Audit, looking at access to real-time continuous glucose monitoring by socioeconomic deprivation. And we can see that over the last few years, the gap in terms of access has actually increased, with those children and young people living in more socioeconomically deprived circumstances having proportionally less access to this treatment technology compared to those who are in the least deprived socioeconomic areas. So this is a really key theme, really key area for us to work on as healthcare professionals in this area, and I think we all have a role in this, coming into contact with children and young people and making sure that they're aware of what's available to them, whether that's specialist paediatric diabetes teams, whether that's primary care, you know, whatever setting you're working. I think it's important that when we do have contact with these young people, we make sure that they're aware of what's available to them and how they can gain access to these treatment technologies. In terms of what we've been doing to try and improve equity of access, it's been a key area of focus for us at NHS England, and we have funded a number of projects across England to try and improve equity of access to treatment technology, and we've provided funding over a period of time to support this, and there's been lots of really exciting and innovative approaches that have been developed with a mix of events to raise awareness through to community outreach, staff training, addressing structural barriers to accessing healthcare, peer support networks, and so on. And we're already seeing a really positive impact of these projects. So the latest data is that we've seen 1,253 new technology starts as a result of the projects that have been running, and with more than 60% of these new starts have been for children and young people living in more socioeconomically deprived areas or from ethnic minority backgrounds. And we'll be ensuring that we collate the information and the learning from these projects so that we can share that widely. Again, as many of you are aware, we were able to get diabetes in the Core 20+5 strategy, and this is NHS England's strategy to tackling health inequalities. And there's an adult Core 20+5, and there is a paediatric Core 20+5. And for diabetes, the two key areas that we have focused on, where the data tells us that there is the most inequality, is access to real-time continuous glucose monitoring and insulin pumps for those living with type 1 diabetes. And then the other area relates to type 2 diabetes and care processes. And finally, just to stress, again, in terms of tackling inequalities in access, often we're told that the language barrier makes it more difficult for healthcare professionals to be able to explain these technologies in a meaningful way. But just to let you all know about the resources and information that's available on DigiBeat. So we were able to commission technology guides in the 10 most commonly spoken languages. And so there's lots of help and information there. So if you're not aware of this, I'd strongly recommend that you have a look at the resources that are available to support you with your work in clinics. And I think we've come to the end, so hopefully time for Q&A.
Absolutely. So thank you very much. I have got a few questions, so I will be asking them to the panel. If anybody does have any questions that they want to ask, please pop it in the Q&A, and then we can go from there. The first question was for Verity, but she seems to have dipped off, but maybe I can ask. There was a comment that the national data was really useful, that it goes down to the ICB level. Is there any opportunity to go further so that people can find out more locally what's happening?
Can I answer that, Fulya?
Yeah.
Because I sit on the adult and young adult advisory board for the NDA. And yeah, absolutely. That's the first version of the AYA audit. And that's the major limitation, that it can't dig into the local services level. The second version, which is being designed at the moment, there is reassurance that there will be aspects of that which will be relevant for a local, regional, and national level. They have reduced the number of things that we're going to be measuring, and that's purely down to workforce issues. But a reduced data set, but it will penetrate all levels.
So it'll make bigger local impact. Excellent.
Correct. Absolutely.
And
Thank you.
I would just add, Candice, for paediatric services, for the National Paediatric Diabetes Audit, the data, you can access that data at service level, as well as old CCG level and ICB level as well. And Verity presented there's an online tool that you can go on to, and you can look at your data and actually compare it to other services, and you can look at your network, for example, as well.
No, excellent. Next question is around the role of CGM in DKA. Does anybody want to take that one?
Yeah, I can take that one. So we know that continuous glucose monitoring is extremely helpful overall for diabetes management, and it can reduce DKA admissions because the person can, rather than intermittent finger prick glucose levels, if you can constantly see what your glucose levels are doing, then you'll know if they're persistently high and that you need to take action and check for ketones and then step in and prevent DKA from happening. So I think it's a really important tool for us going forwards.
Absolutely, thank you. And still on the DKA subject, is there any data around eating patterns and DKA? I'm not quite sure what the level of depth people are, whether it's disordered eating or just how people sort of eating and their risk of DKA.
I'm not aware of any relationship between eating patterns and DKA, sort of in its own right, but obviously if there's disordered eating related to type 1 diabetes and the mental health issues associated with that, then we know if there is regular restriction of insulin, then that can certainly be a risk factor for developing DKA. Often there is these people will actually have quite a high HbA1c as well, and a high HbA1c is associated with increased risk of DKA as well. So I think if we're talking about sort of disordered eating, then I think that's a really important consideration. And as clinical teams, we have to think about what we can do and how we can best support these children and young people to keep them safe, and as well as possible. But yes, in terms of sort of reducing DKA admissions, what can we do to try and keep them as safe as possible so they don't end up in DKA?
Absolutely. There was a question which sounds probably wider than what we can do in this webinar at the moment, but it's around sort of morbidity, so sort of type 1 and cancer. How do we manage these sort of multiple conditions? Any tips or techniques or where to go?
That's interesting. So it's quite a broad question, really, isn't it? And
exactly.
Then cancer in children, cancer in young adults. I think it's beyond the remit. I think I would say, tools such as technology would be absolutely fundamental in a scenario like that, to see how you could, be more. You could apply sort of precision medicine in managing glucose levels, really, isn't it? With those tools. But yeah, it's quite a broad question. I'm not so sure how to answer that. Fulya?
Absolutely.
Yeah, from a pediatric point of view, I work in a children's hospital in a tertiary centre, so this is something that we come across every now and again. Fortunately, it's not too common, but I would agree with Reza. I think the things that are really helpful. So I think technology is really helpful, because what you find for these children is that the diabetes becomes the less important thing, and the cancer treatment has to progress, and you have to be able to be very responsive to whatever's needed in terms of the cancer treatment. And that may involve high dose steroids, for example, which will impact on glucose levels. It may involve frequent trips to theatre for lines, lumbar punctures, various different surgeries. So treatment technology can be really helpful because, you know, if you've got a sensor, you make sure that you're always keeping on top of whatever's needed from a diabetes point of view. The main aim being that you're not aiming for perfect diabetes management, but what you don't want is for the diabetes to cause additional problems. So sensor technology is extremely helpful, and actually pump technology can be very helpful as well, because you can be much more responsive to whatever's going on. I mean, it can be managed with pen injections as well, but yeah, it's a very challenging thing to do all round. I would say, for anybody who's sort of been involved in it, I think they will agree with me on that.
Absolutely, and I think key is communication with all the teams, making sure the oncology team, the cancer team, and the diabetes team are working well together. So one treatment, it doesn't necessarily throw off another. It's very challenging.
That's a very good point, actually, Candice. We spend a lot of our time saying, please tell us what you're going to do so we can plan ahead. Yep.
Absolutely. So the last question we've got is around mental health, and obviously that importance of trying to reduce the burden of living with diabetes, and whether, you know, there's a national shortage of mental health practitioners, and not every centre has them involved in the services as we ideally would like to be. But certainly, you know, there was a question about, you know, can mental health, you know, funding be available to have more support in the clinics for these people living with type 1 diabetes. Any comment on that?
Fulya, me, you?
Well, if I take it from a paediatric perspective, as part of the best practice tariff requirements for, you know, that, and that's how paediatric services are commissioned, all children and young people should have access to diabetes psychology support integrated into the multidisciplinary team. We do know that this is a challenging area at the moment, and unfortunately we don't have enough trained psychologists to go around, and a lot of teams are coming up with sort of alternative ways of meeting that need. But there should be an annual psychology assessment, and there should be a psychologist available, integrated into the MDT. The situation very definitely changes when we're looking at the sort of young adult care and adult care, and so I'll hand over to Reza for that aspect.
Yeah, and I think the question specified around psychology being mandatory. I don't think it's mandatory, but it's aspirational, let's put it that, because we need to understand the ground reality in adult care, predominantly on the level of awareness as well, amongst commissioners, amongst ICBs. So we need to understand the scale of the problem first, and then when you understand the scale of the problem, then we look for whether there are trained psychologists available, and you know, if there are, then most importantly, who's going to fund them, and where's that money going to come from? So it has historically been a massive problem, especially from a young adult perspective, and you know, and there are services where screening is not done primarily for that reason, because if you're going to screen someone and you don't have access to psychology, then why screen them? Isn't it? It's a chicken and egg situation, really. So, but then, you know, it would be quite important for services to understand what is available. It's not like there's nothing available. There are community services available. They are generic. They're not diabetes specific. Waiting lists are very long, but there are options, and that's the thing. But my advice really for any area which is looking to embed psychology within young adult care would be to understand what the burden is. So, you know, do your data analysis, do your QIs, do your measurements to see what that burden is, and, you know, look at examples around the country where psychology has been embedded. How have they got funding? Look around, and then, you know, go to your local commissioners and ask for that. So it is extremely challenging. It's not mandatory, it's aspirational.
Absolutely. There are quite a few questions about DKA and sort of DKA management. I'd like to just signpost that 5-minute online package. We will be sending it out as well, so you will have a link. There are really good resources on learning about the sort of signs and symptoms of DKA and the differences. There was one question I just wanted to reiterate. If you do find a glucose above 11, please send them to a hospital. It's the question about who they should be sent to. There's a question about sort of lag time in sensors and the difference. So if you have a sensor data that's sort of high, when should you finger prick to confirm that CGM data? Who wants to take that?
I mean, I think Fulya, I'll give my views and then Fulya can give hers as well. I guess one of the limitations, we've come so far in diabetes-related technology, and this is the closest we are to artificial pancreas. But like any piece of technology, we need to understand that this has its own limitations. And unfortunately, the limitations occur when glucose levels are in the hypo range or in a hyperglycemia range. And ironically, those are the two extremes that you want the sensor to be most accurate. But unfortunately, this is where we are. We're not checking capillary blood glucose. We're checking interstitial blood glucose. There's always going to be a lag. The lag widens when in those extremes. The lag also widens in a very subjective manner as well. So some people, are on medications which impact the sensor accuracy. So my advice really would be that, look, if someone has very good hypoglycemia awareness, for example, and the sensor is showing that you're in a hypo range, but you're not having any symptoms of hypoglycemia, then that's where you correlate with a finger prick, because at the end of the day, a finger prick is going to be always gold standard. Similarly, if the readings are showing highs and you've got good awareness of the symptoms of hyperglycemia, that's where. So, when in doubt, my advice would be check. And there will be some people who will be better off on a particular sensor as opposed to some other sensor. So we get that subjective variation as well.
And I would say, so I think from a paediatric perspective, I think every paediatric team and service will have their own local guidelines that they use. And I wouldn't want to sort of supersede that in any way. But as a general rule, I think what we would tend to say is that the sensor technology is very good now, and generally we would encourage people to use that technology. But as Reza said, we know that technology can let us down sometimes. So we tend to say if a glucose level is 14 or more, we would be recommending to check for ketones anyway. So that's often a time when we'd say, do a glucose check and check for ketones as well, because we want to know exactly what the situation is. And particularly, it all gets a little bit more complicated with hybrid closed-loop technology as well, but particularly if it's persistently above 14, then we would recommend to do a check. The other time is if, for example, you have concerns about how the sensor is working. So if you don't have arrows there or the numbers are not coming through consistently, we would always say to do a check just to make sure that you're confident that the sensor continues to be accurate. And then the other time I would always suggest doing a finger prick check is if your symptoms don't match the sensor reading. That's another time when we'd always say do a finger prick check. But I think the other important thing to remember, there is a lag with the technology, but you've also got your arrows as well. So what you want to do is take into account the number that you get, but also what the arrows are showing, and does that fit with the sort of the situation that you're in. And we do tend to find that that people who live with diabetes and their families get really good at judging that, and often we're learning from them about the circumstances in which they're in and why they've done what they've done, and so we tend to find that they're very good at judging when they do need to do a finger prick check versus when they can rely on the sensor reading. But just as a general rule, they're the times I would always say do a finger prick check.
Fabulous. And we've got time for just one last question. We've spoken lots about technology, but what about the cohort who don't want technology and sort of are refusing access? How do we support those people? Any tips or techniques or tricks that we can give them the best service as well?
Right, I'll take that first up, Fulya, if you don't mind. And that's a superb question, because I think one of the things that we don't talk much about is, and I keep banging on about this, called technology paradox in young people, where it's the uptake is very good in pediatric care. Once you get into the transition years, into the young adult years, there's a paradox where they use social media and mobile phones and the rest of it very well, but there's a significant drop in wearable diabetes technology, and there are many reasons for that. There are body image issues, you drawing attention in universities and the rest of it. So there's a significant drop, and an absolutely crucial to be aware that if you keep banging on about technology, you're going to drive certain cohort away from tech forever, and irrespective of the numerous advantages it has. So I think it's important to probably highlight that the person, in the consultation, it's always important to make them aware that we're speaking to them as people, and not just their numbers, and not a piece of tool that we're trying to force them to use. That is the key thing, I think. There are better insulins that can be delivered through injections and the rest of it. But I think the most important thing is communicating with them and then making them realize that they're not just numbers or a pathology that we see. These are people that we're talking about, and their views have to be at the forefront of advice. But then, you stick with them, you stick with that sort of period where they don't want technology. And eventually, and we see anecdotally that around the ages of 25, 26, when things are more settled in life, they've got jobs, they're in relationships, the life's just, more settled, they will come back to discussing technology again. So there is a phase that everyone should be aware that there is a drop.
Right time, right technology for the right person. And that will change as the life journey goes on. Absolutely. Anybody have anything else they wanted to share on that topic, or shall we pull this to...
I'll just add really, really quickly, Candice. I completely agree with what Reza said there. I think it absolutely has to be personalised, and there is still lots that we can and should be doing to support young people who don't want treatment. Don't want to wear a sensor, don't want to wear a pump. There's plenty that we can do. I think some of the things for us to be mindful of that happens in pediatrics is sometimes there's a tension between the young person and the parents, and that can be quite tricky to navigate, and that's where our psychology support can be really helpful, and that's where our consultation skills are really key in navigating that area. I think the second thing, again, to be really mindful of is diabetes burnout and alarm fatigue, and whilst what we might want is that those alarms are set at quite a tight range, actually that's not right. And for some young people, the right thing to do is to say, well, we don't want any high alert alarms. It's still better that they feel comfortable to wear the technology and they've got some information about what's happening with their diabetes, rather than an alert going off every time they hit 14 or or whatever you set it at. So I think it's just making sure that whatever we do, it's really individualized, that we ensure that we're putting that young person, that child, in the driving seat of the decision making, but also working really close with families and other allied healthcare professionals that can be really helpful in terms of supporting young people to make the best decisions for themselves.
Absolutely. Thank you very much. So just to finish off the webinar, the next steps is we will be sending out a certificate of attendance and a PDF of the slide deck, as well as all the links to you in the next 1 to 2 weeks. If you do not receive it, please feel free to reach out to us at CDEP at info@cdep.org.uk, and we will find out what happened and send you another email so you can get the content. But thank you very much for attending, and especially thank you very much to NHS England and for our lovely speakers who have shared their pearls of wisdom with us today. So thank you very much. I'm going to draw this Lunch and Learn webinar to a close, and I hope you have the best rest of your day. Thank you very much.